pancreatitis. So I thought we'll discuss pancreatitis in the aspect of a long case and how to answer some SEQs, commonly asked questions in SEQ regarding pancreatitis. Because this time for the proper paper also, I think we had a question on pancreatitis. So usually people with acute or chronic pancreatitis, they present with epigastric pain. So in a long case setting, it will probably be in the context of epigastric pain. Okay. So let's go through the long case format, how it's to be taken. So first, the demographic details of the patient, and then usually I ask what comorbidities the patient has, and the presenting complaint will be epigastric pain of duration. So in the history of presenting complaint, since it's a pain, you can use Socrates, but at the end of the day, what you should highlight in your history of presenting complaint itself is the story, and from the story some differentials, and then the etiology, complications, and management up to now. So usually in the surgery long case, like most of the surgeons, they only pay attention to your history of presenting complaint. So like you have to get everything out there in the history of presenting complaint itself, because to the rest other components of the history, they don't really listen that much. Okay. So now if epigastric pain, if it's somewhat of a long duration, that means like not years or years, somewhere around 3 to 4 weeks, there are certain differentials you must entertain. And if it's of short duration, also there are certain differentials you must entertain. So whatever the duration it is, you can apply Socrates. And if it's of long duration, you have to think of certain differentials. So first one is in a surgical long case, you have to think of very sinister pathologies. So whether it's gastric carcinoma, and whenever we talk about the clinical features of gastric carcinoma, I mean it's better if you can divide into general, local, metastatic, and paraneoplastic syndromes. So gastric carcinoma, people will generally be anorexic, and they will have symptoms of anemia along with asthenia, so that's loss of strength. Along with that, local symptoms will be obviously epigastric pain and discomfort. And if there is a pyloric involvement, there will be non-bilious vomiting, projectile non-bilious vomiting. And if the gastric carcinoma is situated near the gastroesophageal junction, there will be an entity of dysphagia, along with other symptoms such as disatiety, bloating, abdominal distension, and obviously if the cancer outgrows the blood supply, there will be hemorrhage and necrosis, there may be melena and hematosis. So those are the local symptoms of gastric carcinoma. And as you know, metastatic symptoms are with the liver is involved, ascites, right hypochondriac pain, and jaundice. If the lungs are involved, there will be respiratory symptoms. A brain is involved, neurological symptoms, and if there is muscular skeletal involved, bone pain, intractable back pain are also features. And gastric carcinoma, I mean, there are certain paraneoplastic syndromes associated with cancer. For gastric cancers, these are the paraneoplastic syndromes. I mean, I'm sorry, this shouldn't be in green. I mean, it's not need to know knowledge. This is like good knowledge, okay? They can question in MCQs. And if you are doing the long case really well, they will maybe perhaps ask this. But that is the long case is gastric carcinoma. And obviously, you have to ask about the etiologies. So somewhere in your history, these also should be highlighted. So you guys can go through this leisurely. It's a very extensive list. And it's good to remember some of these points as well. Like, okay, smoking and alcohol, they are pretty straightforward. Those they have a relationship with any cancer, blood group A, and any hereditary conditions, colorectal carcinomas, are also associated. Okay, then moving on to the second cancer, where this is epigastric pain of long duration. So you have to entertain the differential of pancreatic carcinoma. So once again, you can divide it into general, local, metastatic, and paraneoplastic syndromes. I can't recall any paraneoplastic syndromes associated with pancreatic carcinoma, but if you guys can, it's good. So once again, generally it will be painless progressive jaundice associated with loss of weight and loss of appetite. So, and the characteristic feature of pancreatic carcinoma is loss of weight and loss of appetite precede the jaundice. There might be even features of recent diagnosed diabetes. You can ask in the history and steatory. When it comes to the local symptoms of pancreatic carcinoma, so there will be epigastric pain radiating to the back, and which may be worse during the night. There will be associated back pain. There will be features of gastric outlet obstruction because the pancreas and the gastric outlet and the duodenum are all in close relationship. And also there can be profuse upper GI bleeding into the gut due to hemorrhage and necrosis of the tumor. So that can result in melena or hematosis. So as you can see, gastric carcinoma and pancreatic carcinoma somewhat almost similar picture, except for the jaundice. So metastatic features are the same. So this is, if you guys can make a table like this, I mean, it's very easy to remember. And you just have to keep on going through it like daily and ask these questions again and again, and then you guys will get the hang of it. Okay, so etiology for pancreatic carcinoma. So these are several etiology or risk factors. So you guys can go through this leisurely. I'm not going to go in detail. So you guys can ask a few of these. Okay, so smoking and alcohol and chronic pancreatitis once again are important etiological features that you must ask in the history. And another cancer is this periampullary cancer carcinoma. So basically, periampullary region consists of the pancreatic head, duodenum, and the biliary tree. So here, the characteristic feature is the jaundice will happen before the loss of appetite and loss of weight, and the jaundice is fluctuating. So that is how you can clinically differentiate periampullary carcinoma. But I mean, these are all very theoretical. I mean, I haven't seen any patients who have periampullary carcinoma having fluctuating jaundice, but it is important to tell these things in the history because that is how examiners know that you know the clinical features of periampullary carcinoma. And when it comes to this surgical long cases, the examiners are for an undergraduate level, the examiners are only interested in how you exclude the different differentials in the history. I mean, and then they don't. I mean, if you do a good job with that, they really won't, be too harsh during the investigations and management, because at the end of the day, those are like postgraduate stuff, and especially if the sometimes in a surgical long case, the diagnosis is not straightforward. So a lot of weight will be put into how the candidate exclude differential diagnosis. Okay. So another differential diagnosis we should consider is chronic pancreatitis. So there will be recurrent bouts of abdominal pain, which is radiating to the back. Will be reduced when the patient is bending forward. Because when the patient bends forward, the pancreas will be lifted off the diaphragm, so the pain will be reduced. Abdominal pain will be worse with food or alcohol, and there will be features once again of steatorrhea, weight loss, and these fat-soluble vitamins, features of vitamin insufficiency, and plus or minus obstructive jaundice. Okay. So then there are the etiologies associated with chronic pancreatitis. So gallstones, alcohol, hyperlipidemia, all important things, etiologies for pancreatitis. And then also there is this entity of autoimmune pancreatitis and hereditary and tropical specific pancreatitis. So just read up on these things. I mean, these are not important. These are MCQ points, though these are not like need to know, must know things. But if you guys, but they will help you definitely in the MCQs, especially these true or false things, because true or false MCQs, they can literally ask anything. Okay, another important differential, not confined to the hepatobiliary system, is your peptic ulcer disease. So chronic epigastric pain, you have to definitely exclude this. So how you do that is a paining or aching type of pain associated with nausea, vomiting, and there is a relationship with meals. So gastric ulcers, pain increases with meals. Duodenal ulcers, pain will reduce. And usually duodenal ulcers, it's sort of like a nocturnal or early morning type of pain. Patient wakes up in the night with pain. Gastric ulcers are associated with loss of weight because the patients will stop eating because of the pain. But with duodenal ulcers, since the pain reduces with the meal intake, they will have weight gain. Okay, so for some features to differentiate gastric ulcers and duodenal ulcers, but like now the book state that you cannot actually differentiate them by clinical features itself, but some examiners are very they strictly believe that you can differentiate gastric ulcers and duodenal ulcers from the clinical history. So it's important to highlight once you think this is a peptic ulcer disease, whether the patient has a gastric ulcer or duodenal ulcer, very important to find. Okay, and another differential you must entertain in a patient with somewhat long duration epigastric pain is following an attack of acute pancreatitis, they have developed a complication like a cyst or abscess. So a condition like that also must be entertained in your HPC, differential must be entertained in your HPC when the patient comes with chronic epigastric pain, okay? Okay, so once you identify a possible cause of the gastric pain, then you have to talk about the etiology. And then along with those lines, a complication. Okay, so peptic ulcer disease, hemorrhage, stricture formation, malignancy. So those are some complications. You can ask the patient what else happened. Did they take you to emergency, theater, and they did the emergency surgery? Because that's the last thing they would do in any emergency is surgical management. In surgical management, you can ask whether he was taken to the theater and when any operation was done. So basically, that's how you take. That's how you complete your HPC. Okay, for each of these differential diagnoses. Okay. So if it's the epigastric pain is of somewhat short duration, we have to exclude definitely. So in a surgical long case, you have to exclude acute pancreatitis. Because that's I put it first because that's the topic we're discussing today. So it will be a sudden onset, uh, uh, sudden onset, severe constant epigastric pain radiating to the back, and it will be relieved when bending forward, leaning forward. It's worse with 30 minutes. And there is early and profuse vomiting. In fact, some people call it wedging. And there might be associated fever. And if the pancreas is very inflamed, it might impinge the biliary tree, producing some entity of jaundice also. And there is also some close relationship with the cause of the pancreatitis also. So following within 1 or 2 days of following like an alcohol intake or something like that, they will get an attack of epigastric pain, and then you should be highly suspicious of whether this is pancreatitis. Okay. So these are also some etiologies for pancreatitis or gallstones, alcohol, trauma, autoimmune disorders, the scorpion bites and all. So these are all once again MCQ points, and definitely if the diagnosis is acute pancreatitis in the long case, the examiners will be asking you, okay, what are the possible etiologies you found in this patient here? So most of the time in the Sri Lankan context, it's alcohol, but the commonest cause of pancreatitis worldwide is gallstones. Okay, so once you identify the etiology of the acute pancreatitis, then you have to look into complications. Okay, so there are like a lot of complications for pancreatitis. So we will go through them one by one. Let's leave this for now. But in the history, how do you ask is basically just ask the patient, okay, whether they were put in the ICU, whether tubes are inserted, whether they had to be taken to the theater or something like that, and he lost consciousness or something like that. You can ask the patient, and they will tell you. I mean, you can't be asking whether they developed a cyst or abscess because they won't understand that language. So you can tell patient was put in the ICU for so many days, and he told he had several cannulas, something like that. In the history, you can tell to give the examiner the impression that this patient has, that this patient has gone into a complication of acute pancreatitis. Okay. Then another differential is GORD and esophagitis. So there will be night pain. The pain is usually in the night and it will be radiated to the back. There will be an entity of dysphagia. pain worsening bending forward, and associated GORD symptoms like belching, burping, regurgitation of food, and all that. Okay. And also another important differential for acute epigastric pain is an acute complication of peptic ulcer disease. So we discussed this again earlier. So sharp stabbing pain, and there is also a long-standing history of epigastric pain associated with meals or NSAID use, history of melena. And also when there's an acute peptic ulcer disease event, usually they present as an acute abdomen. Okay, so there will be you can ask features for fever, generalized abdominal pain, bloating, things like that. Okay, and another differential which you have to entertain is whether this can be polycystitis, okay, and hepatitis. So these are some test symptoms you have to ask, and always an acute coronary syndrome must be excluded. And abdominal, I mean, this unlikely to for us to get a patient with an abdominal aortic aneurysm as the long case, and also an hernia. Okay, so that's it for the HPC. So basically, if I give a summary, so a patient comes with epigastric pain, you have to take their story, you have to entertain some differentials, you have to find the etiology and any complications, and the management done for that patient up to now. Okay, so if the epigastric pain is of long duration, that is 3 to 4 weeks, you have to exclude your malignancies first. So because that is important, malignancies which have a surgical management. So gastric carcinoma, pancreatic carcinoma, periampullary carcinoma. So you have to exclude those, and then also think about chronic pancreatitis and peptic ulcer disease. Okay, and if a patient comes with acute epigastric pain, you have to think about acute pancreatitis, acute complication of peptic ulcer disease, whether this is a GORD or some entity of esophagitis, or whether this is acute cholecystitis or hepatitis. This is an acute, this is a ruptured abdominal aortic aneurysm. This is an acute coronary syndrome, or whether this is a hernia. Okay, so this part is very important, and how to differentiate each are very important. And if you guys go through the KDU SCQs for surgery, I mean, usually the format is they give some scenario, they ask for some differentials, and then the very next question will be, how do you exclude these differentials? So I mean, remembering this is worth it, because this will not only help you score marks for the long case, but as the SCQ as well. Okay, because those are the two components, in my opinion, where you can score marks, because this MCQ is very unpredictable. Okay, and short cases are also, it depends on the examiner. Some examiners will rush you, and then you get very panicky. Even I panic during my short cases. So like it's important to score their long case and SCQs, and this will definitely help. Okay, then it's the rest of the history is as routine. So systemic inquiry, past medical history, past surgical history, drug history, family history, and your social history. Okay, so I won't be going into details, each and everything. This is from the case book, so you guys can go through this leisurely. I mean, these are all covered in the HPC. So if you guys can remember the HPC, and these will just fall into line. Okay. So in the examination, the important things to highlight is the patient's build. In a case of epigastric pain, build. This is assuming it's a chronic gastric pain, because gastric carcinoma patients are very emancipated. So build, whether the patient is febrile, pallor, jaundice is present, whether there's any lymphadenopathy, whether there's features of anemia, ankle edema, and CLCD features. Okay, CLCD features too, because it's a differential for other surgical hepatobiliary pathology. And in your abdominal examination, you have to do a full abdominal examination to see for acute abdominal signs, for any mass, organomegaly, for any masses, for any treatments, and nodules in carcinoma. And you have to end it up with a DR. So this is from Professor Neville's note. So he has given the marking scheme also, what examiners look for in the general examination. So for anemia, jaundice, emaciation, supracandicular cervical nodes, signs of alcoholic liver disease, and in the abdomen, any masses, free fluid, and in your chest examination for any effusions and DR. Okay. So that is how you take a complete history and examination with regards to epigastric pain. So then now we will go on to topic at hand, which is pancreatitis. So this is Duranta's note. I think it's a very good lecture note because it's very concise and important things are highlighted. Okay. So if we go through one by one, so this is basically the definition of pancreatitis. Basically, it's information on the pancreas. The acute pancreatitis is inflammation with acute onset of symptoms. So these things just read, okay? I mean, these things no need to memorize because it's highly unlikely anyone will ask you the definition of acute pancreatitis. And the pathogenesis also fairly easy. So any pathophysiology, it starts with an insult. So you to this picture, you can add alcohol, gallstones, blah, blah, blah. That will cause acidic cell injury. And then there's release of enzymes. And there's pancreatic autodigestion. And then there is an inflammatory response, okay? So these causes, I mean, you can remember this list if you apply this list to your history. So I mean, two birds with one stone, okay? Okay, and then there are several severity or grades of pancreatitis. So mild and severe. So usually severe is associated with local complications and organ failures. And there are these scoring systems for the severity. We'll come to that. So once again, the clinical features, epigastric pain or left upper quadrant pain with radiation to the back, rapid onset of symptoms, and it's relieved with beniform. I mean, all these points must be highlighted in your history, okay? Otherwise, it's not a complete clinical feature for pancreatitis. It's incomplete. And then associated with these nausea, vomiting, and other autonomic symptoms. And then you see, these are all features of acute abdomen, okay? So tenderness, guarding, distension, all that are the signs of an acute abdomen. So it is applicable for even a perforated peptic ulcer, okay? And these are Gray sign and Cullen sign are specific for describing hemorrhagic pancreatitis. I mean, all these two can be like MCQs. Okay, so now this is more theoretical. Now, if in the long case, if you get a case of acute pancreatitis and someone asks, okay, what are the complications? Then you can say, okay, there are local complications and systemic complications. And basically, when it comes to systemic stuff, you just have to think of each system. So cardiovascular, I mean, first thing that can happen is patient can go into cardiogenic shock and death, okay? And then you can think of these arrhythmias and pulmonary, this respiratory system. I mean, the last complications you can get is respiratory distress syndrome, okay? So if it's the genitourinary system is renal failure, hematological DIC. So you can remember a few complications, okay? Okay, and local complications. So an easy way to remember is, so due to the pancreatic autodigestion, there's necrosis. So one sequelae of necrosis is abscess formation. And if it's infect, and another sequelae is, okay, there can be a collection of fluid that can cause ascites. And sometimes this pseudocyst formation can happen. And sometimes this pseudoaneurysm can happen. So these things like try to work it out and then you can remember, okay? No need to remember it as a big list. So this is a bit about this pseudocyst. I mean, patient with a pancreatic pseudocyst can be given as for a long case. So it is very important. And they will probably have some chronic epigastric pain, okay? Or they might have had an attack of acute pancreatitis and now is back for further investigation of the pseudocyst. And they might have an epigastric mass also. So it's very important, any person with chronic epigastric pain, to ask whether they have had previous attacks of epigastric pain and they were admitted to the hospital, and whether they were kept ill by mouth and they were given fluids through cannula and all that, okay? And whether they have some history of alcohol consumption and things like that. Okay. Yeah. So lab investigations in acute pancreatitis. Okay, we'll stop here. Yeah. So now in the exam, you will get a patient with epigastric pain. So how now if they ask how you will investigate the patient, you can tell it like this. You first will investigate to exclude other sinister pathologies and confirm the diagnosis. Okay, so you can do a ECG to exclude an acute coronary syndrome. You can do serum amylase levels to and if it's 3 times the upper limit of normal, it's very suggestive towards pancreatitis. You can do erect chest X-ray to see for AR to the diaphragm that suggests a hollow viscous perforation, and if it's associated with epigastric pain, maybe a perforated peptic ulcer. And always, if it's a female, don't forget urine HCG. Okay, and then you will do other routine investigations, and because for these pathologies, all these routine blood investigations are applicable. Okay, so for full blood count, because the WBC count is also you can assess the severity of the pancreatitis and inflammatory markers. CRP again, once again, helps us to know the severity. Your liver function tests, your renal function tests, serum calcium, and if we are going to prepare this patient for surgery, any patient, any patient with acute abdomen has a chance to go into surgery. So you have to do your blood sugars, grouping TT, and at least a PTI. Okay, and then an imaging. When it comes to imaging modalities, ultrasound abdomen, CTI, and other investigations are your blood gases and lipase levels. Okay, so any patient with epigastric pain, you guys can answer like this. Okay, and that will cover all those differentials you have entertained earlier as well. Okay, so back to pancreatitis. So investigation specific for acute pancreatitis. So serum amylase will be 3 times the level. But however, it's important to know that there is no correlation with amylase level and the prognosis or severity. Okay. So these are the other investigations. So I have included them in that previous presentation document. I'll send it to you all. So that is how you say. Okay. I'm not sure whether I included the serum LDH and serum urea levels. You guys can add it to that. Okay, so imaging in pancreatitis, I mean, these are not very specific. These are once again theoretical stuff. Maybe they might ask in a MCQ or something like that. So this usually these are asked NOSCIs, but I don't think you all have a NOSCI component. So sentinel loop sign, renal loop sign. In abdominal ultrasound, it's not specific. It's not sensitive for that sensitive for pancreatitis, but it helps to exclude other causes. Okay, and determine the etiology. Like if it's the cause is gallstones, it will help to determine the etiology. Other modalities are CT and MRI. So yeah, so diagnosis of acute pancreatitis. So characteristic abdominal pain. That's why the history is very important, and you have to mention all those points like sudden onset epigastric pain radiating to the back, relieved when bending forward, associated with stretching and things like that, and in close relationship, maybe with alcohol, or maybe recurrent right hypochondriac pain, or a known patient with gallstone disease or something like that. Okay. Okay, and serum amylase level 3 times the upper limit of normal, and characteristic findings on imaging. Okay, and presence of any 2 is in diagnostic of acute pancreatitis. So determining the severity of acute pancreatitis. So there are these different criteria. Okay, Branson, Glasgow, Apache, and Balthasar index. So guys, these things I mean, it's very good if you can know these things. And sometimes they might, I mean, they won't ask these cutoffs, but they might ask as a true or false question or something like that. What are the things used to determine the severity? So just go through this leisurely and try to remember at least some. So WBC count, glucose, LDH, those things try to remember. Blood gases, hematocrit, and all that. Okay. And when you're writing SEQ answers also, you guys can include these criteria, okay, that you will assess the patient with this criteria, and then you will get more marks, because then the examiner knows, okay, you know that there is something like this, and you can assess the severity also by something like this. You don't have to write all these things, okay? You can just mention the criteria. Okay, management of acute pancreatitis. So they can even ask this in a SEQ, okay? So this is acute pancreatitis is a surgical emergency. So any surgical, any emergency for that matter, always was mentioned where you're going to manage the patient. So high dependence unit, if it's a severe, okay, and you can use the ABCD approach. And if the Ranson scoring system is more than 3, indicates severe pancreatitis. Once again, HDU setting. Okay, so if you can tell it like this, if you can write your answer like that, then the examiner will be impressed from the get-go itself. Okay, you are mentioning several things, several practical things, and several important things you are considering in the management of the patient. Okay, and then the rest of it is just what you see in the wards. Okay, so any pancreatitis patients, they are kept nil by mouth usually, and if it's but now in the new guidelines, what they say is, if it's mild pancreatitis, patient can be started orally with clear fluids and a low fat residue meal. However, if it's severe pancreatitis, what's recommended is a period of rest followed by enteral feeding via NGT. Okay. So you have to get IV access for the patient, and aggressive resuscitation of fluids is necessary. And if the pancreatitis is very severe, you have to catheterize the patient. And an important aspect is analgesia. So it's always good if you can mention the drugs with the doses and all that, okay? Because then the examiners know that you have been there in the ward and you are aware of how you manage an acute pancreatitis patient, okay? So analgesia is important. It can be done with petidine or morphine, and read up on this multimodal analgesia, okay? IV antibiotic use is controversial. The patient, pancreatitis patients have raging, so metoclopramide should be given, and etc. And when it comes to monitoring the vitals and the urine output is important, because the patient can go into shock. Monitoring for complications like this pseudocyst formation, necrosis, abscess, fistula formation. So you had to look for clinically, you had to look for abdominal pain, guarding rigidity, things like that. You had to look, okay. Blood glucose monitoring is also recommended. And in severe cases, DDT prophylaxis is also admitted. Okay. Okay, so after 48 hours, you can say you will reassess the Ranson score. And if there is no improvement, then there are certain surgical management options. Okay. So basically, I think the best thing for you can use this format, and if you guys, when you guys go to the wards, look at a patient with acute pancreatitis, see the drugs the patient is on, and just add those drugs to this. Okay. And that's how you may write a complete answer for your SCQ. Okay, and investigations wise, this is how you approach. So this is applicable for your SCQs and your long cases as well. Okay. Okay. So that is basically what I have written. HDO, fluid resuscitation, analgesics, nutritional support, antibiotics, and surgical interventions. You can just write a bit about this. Okay. Yeah. But mainly for acute pancreatitis, it's sort of like a conservative supportive management. Okay, so a bit on chronic pancreatitis. So it's a progressive inflammatory disorder where the pancreatic parenchyma is destroyed. So etiologies for chronic pancreatitis, you guys can read through these etiologies especially. Once again, the pathogenesis, it's somewhat same as acute pancreatitis, but this time there's progressive inflammation and fibrosis. Okay. Clinical features, as I discussed earlier, so it's somewhat sort of a chronic epigastric or recurrent epigastric pain picture. And there will be on top of that recurrent attacks of acute pancreatitis, okay, and relief in bending forward. And these are the other associated general symptoms of chronic pancreatitis. So diabetes, steatorrhea, jaundice, because chronic inflammation can, since the structures are so close together, can impinge the biliary tract. Okay? Pathophysiology of the pain, these are very good to know. Good to know stuff. So I'm not going into detail. Okay? These are not these are like extra stuff. Okay, so complications of chronic pancreatitis, they can get bile duct obstruction, duodenal obstruction, because these structures are in very close relation to the pancreas. Okay, so anything that can cause inflammation and fibrosis will compress surrounding structures. And sometimes this inflammatory process can erode into the gut, the pleura, so they can get fistulas. Okay. And these penic vein thrombosis, because all different inflammatory mediators are released and endothelial walls of veins are damaged, so you can get thrombosis as well. And finally, the end result of long-standing chronic pancreatitis is pancreatic carcinoma. Okay. So investigation-wise, you can do plain field abdominal X-rays, and there may be pancreatic calcifications. CT abdomen is the most very sensitive to diagnose parenchymal or ductal disease, chronic pancreatitis. Okay, so when it comes to management, so these are the under these headings only you must write. So better to write when it comes to any chronic management, you say multidisciplinary team approach, where you will get hold of a surgeon, pain consultant surgeon, pain consultant, and any other supportive staff. Okay, so analgesia, and you should write in the headings of analgesia, which is like opioids and these plexus blocks. So you can add for the MDT even radiologists and anesthetists, okay, because they only give these blocks. And other surgical interventions, and so endoscopic sphincterotomy, stenting, and stone retrieval. Okay. And then these are the surgical options for CP, chronic pancreatitis. So you guys can read up. And I don't think you guys, it will be heavy. Chronic pancreatitis will be heavily questioned unless you get it for a long case. Okay. And these are the nutritional and pharmacological things. So diet low in fat and high in protein, micronutrient therapy, steroids for autoimmune pancreatitis, and medium chain triglycerides for patients with severe fat malabsorption. And then there is this pancreatic enzyme supplementation and diabetes control. This is about this tropical pancreatitis, and these are some genetic factors factors associated with chronic pancreatitis. So you guys can read up on these things, and also the case book has a good, very brief, like a summary of chronic pancreatitis. If you guys can take a look at that, everything will be highlighted. I'll show you. So it's page 6, okay, in the Calania book. So it has all the things about chronic pancreatitis and even the management, okay, medical, supportive, surgical. And you can write this long, since chronic pancreatitis is a long-term management thing, you guys can write, it's ideally supposed to be with an MDT approach. Okay. So that's basically it for pancreatitis. So you guys have any questions? Okay, if no questions, I'll end the session. Okay.
Thank you.